This is a 75-year-old male patient with shortness of breath and history of adenocarcinoma of the lungs, who it was diagnosed 2 years ago. And you see in this radiograph, there's a coarse reticulonodular pattern. And when somebody mentions there is adeno-CA and you see coarse reticulonodular pattern in a mid and lower lung zone, that should raise suspicion that there is something going on in the interstitial, right? There's slight thickening of the right major fissure, which could be because of fluid. With the history of previous lung cancer, the differential diagnosis could be interstitial. In addition to lymphangitis, you always mention this can be a case of atypical infection or pulmonary edema, which is less likely because the heart shadow is normal, or interstitial fibrosis because of some chemotherapeutic drugs. So this patient is actually a case of bilateral, as you see, asymmetric interlobular septal thickening, although you don't see architectural distortion. Now, if you don't have architectural distortion and you have such sort of interstitial thickening in the subpleural locations, there is mild peribronchial cuffing here. You see this bronchus, and another bronchus is cuffing around it. Given the history of malignancy, always, as I said, mention lymphangitis. Also mentioned, I would like to look at the rest of the images to see evidence of metastasis, of bone destruction, or lymphadenopathy. Mentioned that you would like to discuss the case with the referring physician for further management. If they ask you for differentials for bilateral interlobular septal thickening, you can mention again sarcoidosis or a lymphoma also, right? And what other questions they can ask? They can ask you what are the common pathologies, causes of lymphangitis. So breast, lung, GI malignancies can cause lymphangitis. Differential diagnosis on the basis of the radiograph. I already mentioned that the causes of bilateral lymphadenopathy, and on the basis of the CT scan interstitial prominence, that is also discussed, sarcoidosis, lymphangitis, lymphoma, etc. Crazy paving pattern in case of alveolar proteinosis can cause interstitial thickening. You can have complicated silicosis as a cause of interstitial thickening, or you can have interstitial pulmonary fibrosis. All have different appearances, but the basic underlying architectural distortion or involvement of the interstitial. All right, this is one of the radiographs where the pathology is actually in your face. It's a clear abnormality where, so I would consider this one as a relatively easy radiograph, that if it comes up in the exam, whenever you see an easy one, never be weak in explaining the findings. You have to take full marks in a radiograph because that might compensate for something which you are missing, or you might miss, and avoid failing on a particular table. This one is a young male, and there is definite unilateral hypertransradiancy of the left lung. You see there is a global is a reduction of pulmonary vasculature on the left side. This is the right pulmonary artery. The left pulmonary artery is either too small or it's not there, but you don't see any chest wall abnormalities. Now, this is an additional findings which you should mention to your examiner. They want to listen. They want to see you saying hypertranslucency, left pulmonary artery missing, or hypoplastic. That actually points to a diagnosis that you're thinking. But when you mention that there is no chest wall abnormality, that actually excludes one of the most important differential diagnoses in this particular case. So mentioning the negative points is also very important. There is an impression of, you see, straightening of the heart border. Otherwise, the heart size is normal, but the contour is straightened. So all these points these point towards abnormality called as McLeod syndrome or Sway-James syndrome, or it can also point to bronchial obstruction. So if you still are thinking whether this is Sway-James or bronchial obstruction, then you mentioned that I would like to do an expiratory view. An expiratory view would demonstrate air trapping, which is very useful. And ultimately, an endobronchial lesion also should be excluded. So precise, but pointing at the right differentials is very important. So you see, this is inspiration and expiratory view. There is again the same hypertransradiancy is noted. There is, as I said, reduction in the vasculature on the right and the left side. Is this is a case of McLeod syndrome, right? So other causes of hypertransradiancy can be congenital, can be pulmonary artery aplasia, hypoplasia, or even congenital lobar emphysema. Sometimes there is the interruption of the pulmonary artery, which is an acquired, or a pulmonary embolism can also cause unilateral hypertransradiancy. This is a very important radiograph which comes in the differential list of hypertransradiancy. You see the left lung, the upper lobe is more lucent looking than the right lung. And this is another patient where the right pulmonary artery is prominent than the left pulmonary artery. So symmetry is very important. We always look at both the sides and mention this to the examiner if you see some sort of asymmetry, if there are no technical factors there. So this is a case of pulmonary oligemia, and this is a distended pulmonary artery in the case of pulmonary embolism. See, is a large, subtle, not subtle, but a large embolus sitting in the right main pulmonary artery. It's extensive and occlusive of the right pulmonary artery. And the main pulmonary artery diameter is also slightly prominent, but not very much. However, if you look at the heart, there is enlargement of the right ventricle. And this ventricular septal bowing is one of the signs of ventricular strain in a case of pulmonary embolism. So if this CT scan is put up to you and you pick up the pulmonary embolism, you have to look at other findings. You have to look at the main pulmonary artery, you have to look at the heart chambers and the interventricular septums, and you have to mention that there is or there is not right heart strain, because mentioning or not mentioning the right heart strain has very important, a lot of importance in managing patients with pulmonary embolism, whether they should go for embolectomy or not. Other cases of hypertransradiancy is, as you see, Poland syndrome, and you see the axillary fold is asymmetric on both sides. This is a case of a patient with absence of pectoralis major muscle. Its CT scan clearly shows a patient where there is absence of major and minor pectoralis major muscles. The case of Poland syndrome, one of the differentials of hypertransradiancy. Patients can come up with lobar emphysema, they can have pulmonary aplasia, as you see in these cases. So the one of the lung will look hypertransradiant and the other one as opaque.
Provided with the X-ray both hands, frontal projection of a skeletally mature patient. I'm looking at the carpal bones, which of the right hand, they show some sclerosis, and however, I do not appreciate any major erosions or and their alignment is also in line. I'm looking at the metacarpals. I see some weak osteophytes in the third metacarpal bilaterally. Apart from that, I'm looking at the phalanges to see for any periosteal resorption or reaction. I do not see any of that. Okay, I can see some erosion in the left hand in the proximal phalanges towards the radial side. Okay, so summing up my findings, I see some weak osteophytes. There is osteopenia, and but there is no acro-osteolysis. The soft tissues are unremarkable. I do not see any calcifications. So I'm thinking of hemochromatosis, but in
Okay, very good. So buzzwords are very important, and this is one example of a case with buzzwords, which is beak osteophytes. Okay, there are osteophytes, as you said, third metacarpal head, small one here. Severe degenerative changes are noted still. So you know there's cartilage loss, especially here and here. You look at this margin and look at this margin. There's some mild sclerosis here, and it's starting to have this cartilage loss. You see the joint space it's starting. If you compare first interpharyngeal joint space with this one, you would see there is a difference. That means there's some sort of degenerative change starting here. But when you mention beak-like osteophytes in a patient who is, so why this patient is diabetic? Okay, so whenever you see hemochromatosis, this explains the history. In hemochromatosis, patient will have a deposition of iron in the pancreas, and these patients can be diabetics. Okay, so what is the most important differential diagnosis on the basis of your findings?
I can't think of one, but there is something which involves the third and fourth metacarpals.
Okay, I'll tell you. Whenever you say beak osteophytes, two things should come to your mind: hemochromatosis and CPPD.
Yes,
CPPD. Right? Yeah. So that's something. Okay, it's always worth telling your examiner that I am looking for calcifications in the what is it called, TFC. So the TFC is 30% of patients with hemochromatosis will have a calcification in the TFC, and the TFC, if you mention it, you will get extra marks. Okay. Right. Okay, hold on. So stay with us. I'll just further narrow it up to you. So this is a case of, you see, cartilage nerving degenerative changes, hook-like osteophytes or beak-like osteophytes, as you mentioned, at the metacarpal heads. It's typical of hemochromatosis, but don't forget CPPD, as we mentioned. So other abnormalities that you look for in such cases is subchondral cysts. And this is a case where the patient has subchondral cysts, joint nerving. The density of bone is normal in this case. So there's no osteopenia.
Okay.
And it's usually when you find this abnormality, there is symmetry. The symmetry is important. Chondrocalcinosis, as I mentioned, fibro and hyaline cartilage involvement is important. The top differential is pyrophosphate arthropathy, which also we call as CPPD, in which you see chondrocalcinosis. The preferential involvement in the CPPD will be second and third metacarpal joints, but it can be seen in others also. And the osteophytes generally are not as large as the hemochromatosis. and you will see the patients with CPPD are much more older than those with hemochromatosis. So if you see a patient who is young and he has features of CPPD, mention hemochromatosis. If you have a patient who is old, then you go for CPPD.
Right.
Enhance. I think this is it for this particular case. What else do we have here? Right. Some more images of the patient. This patient has TFC calcification. Sometimes these patients with hemochromatosis will have a SLAC deformity. SLAC is a scapholinated advanced collapse. You see there is widening of this scapholinate distance. There's excavation of the radius by the scaphoid. Dense calcifications are noted within the TFCC. And these are some additional findings which you can see with patients. 8-year-old male with bone pain, and you see apparently if you see there is blunting of this concentric ankle, not this one. The heart looks a bit rotated. The ribs, if you see, they are abnormal looking. Now this looks expanded, this rib. Here there is a subtle expansion. Here this looks to be notched. Here it looks to be notched. Here it looks to be expanded. This one looks to be slightly sclerosed and expanded. Especially this one, it's dumbbell shaped. Something is going wrong with this patient. There's definitely some abnormality, and the patient has bone pains. So CT scan was done. This patient has a transplanted kidney, as you can see, and the patient has expansile-lucent lesions. So this was a case, the presence of a transplant kidney, expansile-lucent lesions in bones. The first thing that comes to mind is brown tumors of hyperparathyroidism. Okay, so in hyperparathyroidism, you can have lace-like patterns, subperiosteal erosions, intracortical tunneling. You can have resorption in the margins of the distal interphalangeal joints. The articular surfaces can be collapsed. You can have metastatic calcification because of secondary hyperparathyroidism. You can have the examiner can show you sacroiliac joint changes with the transplant kidney. Again, erosions with a transplant kidney, always think of hyperparathyroidism. Soft tissue calcifications in the presence of bone abnormalities, think of hyperparathyroidism. It can always show you a case of nephrocalcinosis, although it is not specific. A nuclear medicine image like this one, where the patient will have extensive uptake in the mandible and different. So this is Abraham Lincoln sign, and there's multiple vertebral body uptakes. Look at this is a polyostotic type of polyostotic type of disease. So multiple bony uptakes, and there's expansion of the bone because, as you know, that the disease is a mixture of osteoclastic and osteoplastic activity. Right, patient can be shown lateral laxity of the skull. This is lucency in the skull. There is hyperostosis frontalis, and this lucis is osteoporosis circumscripta. And the MDP scan shows uptake at the margin of this lesion. This is a very nice case. I would have liked one of you to take this case, but we don't have enough time. This is, I have to check the history. The history, I think, was bone pain, let's say, and left quadrant pain, something like that. So this is a child. You can be given history, which is very vague, but the important thing to pick up is the findings and then to correlate them. So the foremost thing that you see are that there is subtle sclerosis in the humeral head here and subtle here. But if you see the vertebra are H-shaped. If you pick up this finding first, you have almost reached the diagnosis. You just look for additional findings, which you see the left splenic shadow is not there and the splenic flexure is occupying the splenic area. That means this patient has not a splenectomy, and the presence of H-shaped vertebra and some bony abnormalities and sclerosis. It's a case of sickle cell disease. This is a CT scan of the same patient. All right. The sickle cell case can also have gallstones. So this is something to look for in addition to the previous findings that I explained. This is a case of sclerosis. You see osteonecrosis in the right femur. This is a patient with impotency, so there is a penile implant there. So on a single radiograph, you can have different phases of a single of the same pathology. So osteonecrosis with a penile implant, although difficult to correlate, but if the examiner gives you more radiographs and you have these findings, you always point towards sickle cell abnormality. All right. Patient can have different levels of osteonecrosis at various places, like the vertebra collapse as a result of this osteonecrosis.